Good morning, Australia. Buenas tardes. Boa tarde, America Latina. My name's Noel Campbell. I'm the Associate Director of the Australian National Centre for Latin American Studies here at the Australian National University. With my colleague Luis Salvador Carula, the head of the Centre for Medical Health Research, it's my great pleasure to host this second session in a series of 5 webinars on the public health and policy impact of COVID-19 in Latin America. In line with the custom here at ANU, we acknowledge and celebrate the first Australians on whose traditional lands the university is located and pay respects to their elders past and present. I'd also like to acknowledge the assistance that we've received from other universities, the University of Newcastle, Notre Dame, New South Wales, and the Sydney University Research Community for Latin America. As you can see from the slide, today's seminar will focus on the public health impact of COVID-19 in 3 Latin American countries, Brazil, Chile, and Uruguay. I'll shortly call on my colleague, Francesco Paolucci, to introduce the session and our 3 speakers. Please note that all the webinars in the series will be recorded and made available publicly. And after the 3 presentations, Francesca will moderate a discussion drawing on questions we invite you to submit using the chat function at the foot of your screen. If you need to contact any of us during the session, please also use the chat function to send a private message. You can also follow comments on the presentations via Twitter by going to the handles indicated on the screen. But before passing the floor, or should I say the screen, to Francesco, let me provide a brief summary of the main points made in the first webinar, in case not all of you were able to participate. We tried to go beyond the stereotypical image of Latin America to answer the question why Latin America matters. We concluded that owing to its diversity, its resources, its rate of economic growth, and the maturity of its institutions, in political and economic terms, Latin America indeed matters. We then discussed the more specific question of whether, in terms of public health and health policy, Latin America's experience also matters. We looked at the strengths and weaknesses of the region in dealing with COVID-19. We traced its evolution since March, from believing that Latin America had the pandemic under control to it becoming one of the world's epicenters. And we considered the broader impact of the pandemic on the health, political, and economic situations of the countries in the region. Our conclusion was that the handling by governments of the health impact of COVID inevitably impacts also on the politics and economies of individual countries. 3 Australian researchers then commented on a study they had done on the government responses to the pandemic in 5 Latin American countries. They underlined the diversity of the region, which meant that there cannot be a one-size-fits-all response. That said, they also noted that the 5 countries had certain common characteristics: high rates of poverty and informal employment, the strain the pandemic had imposed on the healthcare systems, especially on health infrastructure, staff, and availability of equipment, and the relative lack of investment in medical research and technology. The evolution of the pandemic globally had also yielded some positive outcomes. The delay in the arrival of COVID in Latin America enabled countries to learn lessons from the successful handling in China, Korea, New Zealand, and the failures in Europe and the United States. It also enabled them to act quickly and strongly on mitigation and containment measures. And it's fair to say that public health capacity has increased across the region as governments shifted resources to try to manage the health and economic impacts. The trouble is, in practice, there was often a gap between the announcement of intervention measures and their implementation. In some cases, measures were lifted too quickly. In others, they were doomed from the outset because of the socio-economic disparities within countries. For example, in countries with large informal sectors, lockdowns could not realistically be enforced strictly, as those workers had to mobilize and socialize in order to feed their families. In other cases, communication was a problem. Different levels of government, whether they be national, regional, or local, conveyed confusing or conflicting messages. In some countries, this even occurred between different ministries and agencies of the same government. Epidemiological data from the Australian studies showed that the impact of COVID in Latin America was both indirect and direct. The direct effect was on the ebb and flow of numbers of cases and numbers of deaths. In some countries, the record was encouraging, and others it was significantly less so. Indirect effects included the diversion of resources to contain the pandemic, which led to the suspension of health services for other conditions. For example, admissions for respiratory and cardiovascular diseases fell. Similarly, there was a decline in routine immunizations. The pandemic also had an impact on medical innovation and technology. It exposed for all to see years of underinvestment in the health sector. In countries where supplies of protective equipment, testing kits, and ventilators were lacking, they often faced roadblocks in the global market owing to export bans. But on the positive side, these led in some cases to local initiatives to produce supplies. Another positive spin-off was the increase in capacity to provide telehealth and online services for health professionals. Another speaker gave an overview of efforts to model the impact of public health interventions in Latin America, such as social distancing, mask wearing, and school closures. She flagged that modelling was difficult since it required relevant and accurate data. While the rate of transmission was a key indicator, this varied from country to country and even within countries, depending on how quickly, how strictly, and how effectively intervention measures were introduced. In order to be accurate, good quality data from testing was required. And again, the record in Latin America had been uneven. Levels of testing in countries like Uruguay had been exemplary and yielded a lot of data, whereas in some larger countries, data collection had been a challenge. Looking at daily reproduction rates, the study showed that in those countries where social distancing and other intervention measures were introduced early during the first wave, daily reproduction numbers had decreased. But where those measures had been introduced later and less strictly, daily reproduction rates had increased. Similarly, the lifting of intervention measures too quickly after the first wave had meant countries were caught short when the second wave occurred, and daily reproduction numbers showed a rapid increase. Well, that concludes my formal remarks. Let me now pass the screen to my colleague Francesco Paolucci, the Professor of Health Economics and Policy at the University of Newcastle, to introduce the subject of today's webinars and the speakers. Francesco, over to you.
Thank you, Noel, for the wonderful introduction. Apparently, you have to stop sharing, beautiful, so that I can share my screen and welcome everybody, and thank you, Noel and Louis for the organization of this series of seminars focusing on Latin America. As Noel discussed before, we focused on Latin America more from a public policy and economics perspective, and also analytics perspective in the first webinar. Today, we have the pleasure to welcome a fantastic group of speakers from Brazil, Chile, and Uruguay. And today we'll talk more about the public health impact of COVID. There has been a lot in the past months published around this topic, and clearly now more significant evidence is coming out, not only from LATAM, but in a global sense in terms of the cost impact of COVID on the global economy. But today the focus will be mainly to understand more what's going on in LATAM, and in particular in Brazil, Chile, and Uruguay as far as public health is concerned. So the first speaker of today is Denise Razuk, and it's a pleasure to welcome her here. She has a fantastic CV in contributions both to the public policy debate and in the academic work. She's a psychiatrist, and she's based at the Universidad Federal de São Paulo. And has also focused in health economics in her times in Europe. Following Denise, we have Carolina Velasco, who is a long-standing collaborator of mine and others who contributed also to the special issue that the Value in Health Economics and Policy group put together that was just published in Elsevier's journal, Health Policy and Technology. She is a researcher in health policy at the Centro de Estudios Públicos in Chile, which is a very prestigious think tank. She has also worked extensively in governments, both in terms of education policy and also in terms of health policy. And she's currently doing this work in various committees for the government, advising on social related policy issues. Last but not least, our Uruguay contributor, Jose Arcos, who is associate professor at the Thorax Institute, University of the Republic, is also a member of the National Academy of Medicine in Uruguay, and he has a long-standing dedication to science, advising in a number of groups and committees, and of course, very involved in COVID-related work. So without further ado, I would like to introduce our first speaker and leave her the floor. Please, all of you participating, feel free to contribute to the discussion using the chat. Write your questions, engage. We, of course, will try to do our best to collect these questions and to make it as interactive as possible when the moment for the Q&A happens after the presentation. So Denise, welcome, and please take it away.
Thank you, Francesco. Good morning to all and good evening. I want to thank you the invitation to be here in this meeting. It's a great pleasure. I'm going to share my presentation now. Well, I'm going to talk a little bit about the scenario of COVID-19 in Brazil, and just a little description of our health system. Our health system is free with universal health coverage, and we have a population of 210 million people in Brazil. Of these, at least 2/3 of the population depends exclusively on public health care. Less than 25% have some sort of private care, and 25% is under 18 years old, and 16% is older than 59. And in the middle, we have 100 million people in working age, and most of them in informal markets. Our health expenditure is around 9% of our GDP, but actually public health expenditure is less than 4% of our GDP. We have 27 states and 5,500 cities, with all of them with primary care centers. But this scenario is not the same for hospitals and intensive care units. As you can see, we have 22,000 beds for intensive care, but this covers only 10% of cities. Also, with the distribution of health staff, we have a lack of doctors in many places, especially in the poor areas. And then you can see here that you can vary the doctors per 1,000 inhabitants is around 1 to 3, depending on the area. It's the same scenario with nurses and other health professionals. Well, as you may know, our context and our scenario is not good in Brazil. We account for more than half of Latin America case and almost that 10% of world case. And we reached today 5.7 million people infected and 163,000 deaths. But this number is underestimated, probably have much more. And here we can see 2 curves about the new case over time and about the deaths. And as you can see, we started on February our first case, and on April especially, we started to see the rise of the number of infected. And in May, June, and July, we reached a great number of infected very rapidly. And we stay at a plateau. It was not just a peak, but we stayed at a plateau until October. And now it started to decrease and then to increase again. And here, the curve of death, also a plateau. We reached more than 1,000 people dying a day. Now we have around 500 people dying a day, unfortunately. What kind of policy we implemented? I called it the so what policy because Lancet has published an editorial on May about our president, Jair Bolsonaro, because his attitude against the pandemic, he denies the pandemic, and they always say, so what you want me to do? And what is the consequence of this policy is that as the number of cases increased and the number of deaths increased as well, he didn't change his speech. It's always like, this is nothing, this is my code, I don't believe in this number, it's nothing important. When you saw the number of infected increased by 7-fold in 2 weeks only, he just got fired our Minister of Health, Luis Henrique Mandetta, that was doing a very good job. He was trying to map the needs of countries and the region, and he established the quarantine, and the president was against the quarantine, and he didn't use masks. He was completely against all measures implemented by Luis Mandetta. And then the second Minister of Health didn't stay more than 1 month. And after that, we stay without any kind of Minister of Health and no officially national health policy. And then the situation only gets worse. I want to talk a little bit about what we call invisible people, because our Minister of Economy was very surprised to know about what he called invisible people. This is people that are excluded from society. They are in formal markets, or maybe they live in slums. We have more than 25% of people living in slums without water sanitation. Our unemployment rate is growing. We have now 14% of unemployment. And then with this scenario of dismissal, political dispute, corruption on buying the medical device and respirators, etc. And then we see another very sad scenario about 65 million people asking for social benefits because they stay completely without income. And also we saw 220,000 people going to live in streets because they lose their house, and almost 800,000 small and medium enterprise declaring bankruptcy. It was a very, very terrible scenario. Well, we just applied several policies. Social distancing, quarantine was the most common. We constructed campaign hospitals to increase beds for intensive care. Lockdown was used in some small places where intensive care was 100% occupied. We have mask and soap distribution, especially the civil society get the job, NGOs, everybody wanted to help. And then almost telemedicine and prescription validation extension call for health professionals. 10,000 doctors were volunteers to help with COVID-19. Medical students were allowed to graduate early to help. And also we have a lot of guidelines, videos, platforms, and all kinds of educational strategies. Progressive flexibilization, and this was a problematic issue because this started exactly in the peak of the pandemic here. Our government purchased vaccine, especially from Oxford, but we also have some agreements with CoronaVac from China. And we have 2 research centers in São Paulo and Rio de Janeiro, and our university also are testing the vaccine. We are also had some social benefits, fiscal tax reduction, and support for jobs. Well, the main challenges in these situations obviously was our president, but not only this. I think that the time delay between the measures declared and their implementation was a big issue. It was not possible. We didn't see alignment between economic and health measures. You cannot say to people stay home if they don't have food. You need to align the measures of benefits and health measures. Lack of population COVID testing, it was very complicated. Social distancing slums is a big challenge. Lack of safety equipment for all health professionals. Anti-scientific approach. Our president prescribed the chloroquine for everybody, and also fake news was a big problem here. Globalization issues. We faced barriers to buy respirators. We bought respirators from China, and then President Trump blocked our both purchasing. It was complicated, and all these scenarios, the consequences where we saw global health indicators worsened, decrease on children vaccination rate, surgeries were suspended, services were closed, changes in lifestyle and obesity and consumption of alcohol and sugar, and also mental health issues. Well, the good news is that even with this awful scenario, we had some regional health councils from the states and municipalities in partnership with PAHO, and they wrote a guideline to decision support for policymakers and health managers, and then to organize states and municipalities, and primary care has a very big, important role. And then they created 6 key indicators to establish which kind of policies more adequate for each region. For instance, if you are with all intensive care beds occupied, you can be in the purple or in the red zone, that everything is closed. We only can have essential service. And every 2 weeks, you can revise these indicators, and then you can move to another kind of quarantine with open some sectors, and then you can move, and then you can control each region with a different context and see what is necessary to do. This is working more or less well. Then also this regional health councils and with our schools, our health national system is very strong, and they made several approaches with health managers, primary care, population, health professionals, the mayors, especially in small cities, participated a lot. And we saw more than 830 projects sharing experience, good experience in how they deal with the situations in local situations. And then these councils make a virtual congress to share experience and successful experience. Then what should be done? Of course, integrated national policy is very important. and governors' responsibility and commitment is crucial. Scale up testing, prioritize vulnerable groups, especially in economic, social, and health measures, not only economic. And another very chronic problem in Brazil is policy measures inspection. You see here, it's a photo of a beach in Rio de Janeiro when it was not allowed to be on beach. There were some fines, but people don't care to see. Then, yet, what we should we can do, support health professionals, media and stakeholders and government should give clear message with good quality and information, because people became confused about what is true, what is not, a lot of fake news. And another thing that is very important, internet and digital technology available to all. We have a lot of problems with internet, not everybody is included. And also what is worked very well, it's WhatsApp in mobile, that if you have a number that you can talk with everybody in the health system to get advice about your health, about the probability to get or not to get COVID, and how to search for a treatment. And these were good, but the problem that there are many people don't have mobile to have WhatsApp. Also, we need easier access to treatment information. Basically, it's crucial. You cannot forget about that. And another thing is not bureaucratic requirements to poor people to get help, because it was very hard to get the social benefits. And here, the good thing is that our engineers produced a portable single for the homeless. And another engineer from Universidade de São Paulo, in partnership with the FAPESP, created a ventilator that can be produced in 2 or 3 hours, very rapid. And the good thing is that it's 15-fold cheaper than the conventional ones. Then this is a good initiative. I thank you for your attention. Thank you.
Thank you. Thank you, Denise, for your wonderful presentation. We are collecting some questions, and we will address them after the 3 presentations collectively. So now I would kindly ask Carolina to share her screen and commence her presentation. Carolina.
Thank you, Francesco. I also want to thank you for the invitation. I'm very happy to tell you about Chile, or the situation in Chile now. Let me just check, can you see the presentation? Great.
Yes.
Thank you. Okay, so I will try to address 3 items today. Tell you something about the organization of the health system in Chile, tell you about the evolution of COVID-19 and the actions taken here, and finally some lessons, some comments that we can also share at the end in the questions. So we have a mixed health system where we have a mix of public and private initiatives. We have a first layer of mandatory insurance, where 2 main components offer this insurance, which are FONASA, which is the public insurer. 66% of the population is affiliated to it. And also we have some private insurers, only 6 compete. So we have 70% of the population affiliated to those insurers. And they in general cover hospital and outpatient care, but they leave out pharmaceuticals. So that, and I will show you, we have a very high out-of-pocket expenditure because of that. And we have also a pack of warranted health conditions or the treatments for those conditions, which you are allowed to make them, how do you say, to make them accessible, because they are assured, and they, for example, set a maximum copayment or a maximum of waiting times and things like that. So we have this kind of minimum package. And on top of that, we have these voluntary insurances, not regulated, so they can cover anything, copayments or not covered treatments or anything you imagine that they can offer. So in general, we have if you see, of a mixture of systems. We have this, we have this kind of national health insurance, which is FONASA, which just collect the 7% contribution, salary contribution, and also a big subsidy from the state, kind of the SUS that Denise was describing. But also we have a combination of private and social health insurance system for ISAPRES. So we at the end have, or we face the problems of both systems. If you think only on the unique systems, we have, or the national health services or insurances, we have important waiting times, which are getting greater with this pandemic. And also we have risk selection and exclusion on the private sector. So we have kind of this mixed system. Universal coverage is still not achieved, although more than 90% of the people is affiliated to some insurer. The out-of-pocket payments are great, and because of the exclusion of some services, and also because of copayments, and the quality of the services is not equal, depending on which provider and insurer you are affiliated to. So we are facing those challenges in terms of integrating systems and, to reduce out-of-pocket and also increase quality. So what happened with COVID in this scenario? We have a rapid increase from May onwards with a peak in June. If you see the left, the left side graph, you can see the number of cases. We have our first case in March 3, and then we have a very steady increase, so we were very happy. The government announced that we will going back to some activities like, I don't know, public servants were going back to work and things like that. But just after that announcement, we have this incredible increase, very steep increase, and which was a peak in June and then started to decrease. And now we are kind of still decreasing, but very, very mild decrease. And in terms of deaths, that's the same. We have this peak the same in June, and then it started to decrease, and now we have this steady decrease. In total, we have 500,000 cases and almost 15,000 deaths out of a population of 19.5 million people. In terms of occupation rates for the beds, the strategy, and I will talk about that a bit in a couple of slides, the effort was put on increasing beds capacity and also testing capacity, because we knew we were very low in relation to even other countries here in the region, as Brazil and Uruguay, in fact. But in compared with OCDE, we were in a very low level for the number of beds per 1,000 inhabitants, and the same with nurses and doctors. So we reached, although the increase in the capacity was very fast, we reached the 80% level of occupancy, which was kind of a threshold where saturation is important, because you cannot give the same attention and care to the people when you are full. So you can see that in the right hand graph that in that time in June we have the rate of death in relation to discharges because of COVID was greater, probably because of the care was with a less quality because of this big occupation or saturation of the system. But having said that, we didn't face really the dilemma of the last bed, what it was faced in other countries of the region, like Ecuador or Peru, where they really didn't have where to treat people. In terms of the other social and economic impacts, as other countries, we have a very sharp increase in unemployment rate. The same in other aspects like mental health. 50% of the population, according to a recent survey, was experiencing serious psychological stress. So we know we have that the impact is more than only death and people being ill. Is also economic, is also in mental health and many other indicators such as education that I didn't have time to comment. So what was the Chilean strategy? We didn't have a previous plan like other countries for emergencies or pandemics like this one. And so I want to tell you about the four, the measures we took in the four aspects or domains that some international institutions recommend to address when you face a pandemic like this one. In relation to mitigation and containment measures, we have early closures, but we didn't have a total lockdown. We have these moving and selective local quarantines according to some sanitary criteria. So municipalities or counties were closed according to those criteria. Sometimes two municipalities that were very close, one was in a lockdown and the other one wasn't. So that enabled us to do some comparisons in terms of the study, but it was in that sense, and it was criticized because the mobility between two neighborhoods which are close is complicated to control. So in relation to economic support, we have early measures to increase liquidity, but the economic support for workers and families was gradual and was late for the informal sector. So something similar to what was commented before. We kind of leave out the more vulnerable or the poor, which was addressed, but in a late stage. Regarding the pandemic management or the coordination and communication, which was also mentioned before, especially at the initial times of the pandemic, the information was confusing. We have this announcement of new normality at the end of April, which just brought us this increase in the cases and death. So, and also we didn't have a good coordination between, for example, the national level and local levels. So we have some problems, for example, in what was the role for municipalities in testing or tracking. And it was mentioned at the beginning by Noel, we have some differences even between a same institution regarding, for example, the number of deaths or the number of cases. And in relation to the health response, the effort was put on the strengthening of the health system capacities, as I told you, and testing was also very important, but it couldn't increase at the pace we wanted because we have some shortage for the inputs, like I think other countries. And what we did really bad at the beginning was the tracking and isolation of people. I think we did an effort on searching for people and testing. We didn't have enough tests at the beginning. We only have one laboratory. So those capacities were developed after, but at the beginning we were not able to track every person and to isolate them properly. So if you see, also what Denise was talking, we experienced the same in Chile. If you compare what happened in the neighborhoods which experience a higher or a high level of economic income, you can see that after the quarantine or the lockdown was implemented, that is the red line, cases, which is the blue line, started to decrease. These three are like rich counties. But if you go to the other ones, which are the low income or lower income counties, you can see that even after the quarantine was implemented, the cases still started to increase or continue increasing. In that sense, we do believe that the economic support was not timely, particularly for the most vulnerable. If you see this timeline, you can see that the quarantines were implemented, local ones, the blue points were implemented sometimes in March or April, and a massive one was implemented in the middle of May, which is the blue point, the last blue point. But the economic measures were taken after that, were implemented after that lockdown. So a lot of people could not stay at home if they don't have the means, especially if they work, at the informal sector and they live on the daily income. So that was, I think, an important takeaway from our experience. The same with the health response. As I was telling you, I think the most important failure or deficit was that we didn't have a good system for tracking people. This graph is a bit complicated, but I'm just trying to show you, for example, the yellow squares show the increase in people doing the tracking, in tracers. We only have an important increase after the peak in August, and we have the peak on June. The same if you see with, for example, tests. We have a rapid increase at the beginning, but then we keep the same pace. That is the continuous blue line. And after that, we are now in important testing levels, which are like adequate for keeping the pace. But nobody knows what's going to happen next. So I think, thank you. I will close. So I think also we didn't make good use of the sanitary residences, which were places for the people that do not have where to stay or to isolate. So the main conclusion is that the decrease in the cases did not really start when the quarantine or the massive lockdown was implemented, but when all the other measures like kind of coincide. Let's say the support, the economic support, the testing and tracking more intense, and also a better communication and information to the population. So what we can take as lesson is that we need a plan for if we are going to face new, emergency like this one. We need a plan. The economic support as well as the health response should be earlier. The same with communication. That is very important, for example, for the plan. We need to be coordinated to know what is going to happen, what every actor needs to do. And we also have some challenges for the long term and for the living with the COVID, which are the surveillance. We have now in important levels of testing, but we need to, make them like a routine situation and be prepared to address, a second wave if we experienced it, like every other country. So I leave it like here, and we can talk more in the question and answers space.
Thank you, Carolina. Very interesting insights. Now I would like to invite Jose and to share his screen and to unmute. Jose, we can't hear you. You should unmute your microphone, please.
Thank you, Francesco.
Beautiful. Yeah, we can hear you. And if you have slides, you should share your screen and upload them using the share screen function, which is highlighted typically in green.
Yes. Somebody's sharing. Okay.
Yes.
Can you see my screen?
Yes, absolutely. Yeah, thank you very much. Take it away. Thanks.
Okay, thank you, Francesco. It's an honor to be in this webinar, and thank you especially to Noel Campbell for inviting me. I will try to adjust to this program to summarize our experience in this year of pandemic. Uruguay is a small country and with quite short population, 3.5 million, and with the density of population very low but uneven. Our main movement is concentrated in this metropolitan area. 1.5 million people move around Montevideo, the capital. We're not a rich country, as you can see by the GDP, but we have a stable poverty and unemployment percentage. Also, informal employment is always stable and decreasing. Basic sanitation and drinking water is available for everybody, and our literacy rate is quite high. Concerning our health risk factors, we are theoretically a target for SARS-CoV-2. We are an aged population and aging day after day. Our risk factors are obesity, diabetes, and hypertension, as many countries. We have some good characteristics like vaccination since many years ago. Our health system is now in place, a new health system since 11 years now. And the particularly characteristic is that the financial sources of this health system is proportional to the income of anyone. Employees are taxed with 3 to 6, depending on families and characteristics. An employer first give 5% of what they pay. The money coming out of pocket is quite stable and low. This generates two funds, a fund for general medicine and a fund for specialized treatments or high technology treatments. And it constitutes as a global capitation system, giving money to the providers, public or mutuals. It divides just like something like 60 to 40%. And from this fund for high technology treatment. And the providers are giving what is needed for treatment. And I would say that there are differences between public and mutual system, but they are diminishing. What is remarkable, I would say, is that the increase in healthcare expenditure has been stable during the last 15 years and surpassing the growth of the GDP, as you can see in this graph. We are now spending near 10% of our GDP in healthcare. That is not far away from what are the average of the OECD. And out of pocket is in this range. Resources in terms of hospital beds is a little bit low, but an ICU and ventilators were around 20 that were rapidly upscaled when we knew that our first cases arrived to Uruguay. So this was a big effort, but until now, we didn't have to use them. In terms of physicians, we are quite good in Latin America. We have 5 physicians per 1,000 inhabitants, not so much in nurses. What is our current situation? Well, we're testing, and we are testing with PCR. We had not used until now the serologic tests. The full capacity of our testing was fully set in place around June and July, and we are now near 90 or 100,000 per million people. That is enough for a country. Also, the positive share of PCR tests has been steadily low, under 2%, and especially in health workers, it's around 1% that has been tested extensively. The cumulative number of cases has increased, but not exponentially. We are now in 3,000 and something the last week, but it is increasing like something like 10% per day, never in an exponential way. These are the outbreaks that we experienced that were easily identified. The COVID entered our country early March, coming from Milano, and in a social event that spread over tens of people the disease. Then there were hospitals or border towns with outbreaks, always in the low range. And after the municipal elections held in September, we experienced a steady increase that has reached yesterday the record, 80 cases a day. And we expect that this is going to increase, perhaps coinciding with the rate of spring. And
Jose, can I ask you to speak a little bit louder for the recording? Thank you.
Yes. I try to get near the microphone. This small increase took us to the yellow zone of the Harvard model. We are now in 1.5 to 2 cases per 100,000 people, talking about 7 days moving averages. We were in this month, since March, always staying in the green zone below 1, but now we are near 2. So it's been an alert for us. In terms of severity of diseases, they were always mild diseases, just something like around 2% were severe cases, and deaths always observed in elderly people had been just as observed case fatality ratio below 2, and also in mortality also equal to 2. This is the number of active cases yesterday, and it's been always very far away from our capacity of ICU beds or ventilators. How were the health policy actions? Were quite early. On March 13th, a week later, after the first cases, we started the mitigation and containment. The declaration of health emergency was in place. The borders were closed. A quarantine was implemented for travelers. The suspension of public events. All classes of schools were closed and continued by electronic media. There was a stay-at-home directive. There was no mandatory lockdown on neither curfew during these months, and strong exhortation to elderly people to comply with this preventive quarantine. Hygiene measures and responsible use of public spaces were also put in place. The second stage of the health policy action was the gathering of a scientific advisory group that had an exclusive advisory role divided in two groups. One group taking charge of health planning, and another group with mathematical models and data handling. There was no political interference with this group, and its main duty was advice on the management of the pandemic and how to transit to that called the new normalcy or new normal. We followed these criteria and we are stick to them: progressiveness in resuming activities, regulation, always using a protocol, monitoring on-site and online, I would say, every activity that opens, and always guided by evidence-based models and not by other reasons. The heads of this group also collaborated with the creation of a consortium between the university and the Institute Pasteur of Montevideo and a private company for the local development of manufacturing the PCR tests. We didn't have enough laboratories to do that, but that was rapidly put in place with groups with experience in molecular biology. They made a kit for PCR test that was rapidly available, and also sequenced the first complete genomes of the virus from the first time patients in Uruguay. And also in these days, they had developed the LAMP test and serologics test to use with epidemiological purposes. The actions were massive testings. We started with 30 tests a day. Now we are in the 4,000s a day. There was extensive tracing, creating a new unit in the Ministry of Public Health of people tracing the contacts. The home assistant with doctors with encouraged. It is generally available, the telephone and telemedicine in our country. In hospitals and clinics, there were clear-cut protocols, and what was about surgical procedure was really restricted just to emergency and oncology, especially the 3 first months of the pandemic. Well, if we look at the stringency of these measurements, Uruguay perhaps has been not so strict as other countries in government response and in containment and health measurements. And this correlates not very well with the number of cases, as you know. What has worked well in our country, well, we think that border closure and isolation measures were very well followed by the population. The test availability and independence, not dependence on the importation of kits, were rapidly developed. The decisions were taken by the political system in conjunction with the science community. That is a very good characteristic of what had happened here. And the resuming of public activity was always progressive. How was the compliance with these measures? Well, this index, I think that it shows that was very well compliant with people following the advice of stay home the first months, and that is decreasing also with the course of time. The management of the information, I think, is another remarkable
2 minutes, Jose.
Thank you. We have clear data online about the number of cases each day with geo-reference, the occupancy of the ICUs, the rural schools open, and the flow of travelers arriving to our country. We are usually during winter have a lot of severe respiratory infections in children and in adults. As you can see, in 2018 and 19, this is the peak in winter that we didn't have this winter. And in adults also there were, this is the peak of the COVID, but there was nothing in comparison with winters before. That's a good thing. What should be improved? Well, we don't know if we will have at the end of the year an excess of death. There is some research that mortality rates could increase during economic recessions, but we know that we have negative health effects associations. The delay in laboratory studies and treatments of the patients will, without doubt, have an impact, and in vulnerable populations also. The social and economic impact has been considerable. There is a decrease in the GDP that will not recover immediately, and the labor market is affected. The employment has increased 2%. There are some measurements with expanding and facilitating the insurance of unemployment. It's declared an occupational disease. There is a coronavirus fund made by discounts in the salary of public officials, and taxes and social security contributions will be deferred. What is happening with the next months, or what will happen? What we are expecting? Well, we receive each summer 1 million of tourists coming from Brazil and from Argentina to our crowded and non-crowded beaches. We are continuing with the containment and mitigation to trying to return to the green zone with early detection, tracing, and perhaps using serological tests. The borders will remain closed during summer. That is really a novelty for our country and has been accepted. The social and distancing measure will be continued, and Uruguay has signed the COVAX facility with the WHO to acquire vaccines that were put in place and have proved its efficacy and safety for the 20% of the population, perhaps for next year. Thank you very much. I will be glad to accept questions if there are.
Thank you very much, Jose. Yes, very interesting presentations and insights, and with quite a lot of variation in the approaches, also in terms of border controls and public health measures. I would like to start with the first question that is actually about, it's to Denise, and it's about the issues that were probably mostly occurring in the very first phase, but there was an extensive period of uncertainty in terms of the position of also the public policy makers. So the question goes like this: is the main challenge human denial of scientific evidence, or is it an hypothesis of irrationality, as shown by the COVID policies that were introduced in some governments, including Brazil? Denise?
I think that several factors are involved. For example, our first Ministry of Health, Luis Mandetta, wanted to everything implemented here was guided by science. But what happens that he becomes too charismatic, too popular to people, and then president didn't like this political popularity and said, stop. You know, I think that there is a lot of political conflict of interest. Our president understood that he can be popular, giving social benefit to people, and then he can gain the next election, you know. And then he cut the Minister of Health because political issues. It's not exactly because science. He's not worried about science. It's irrational, and it's more than that. It's much more complicated than that. And I think that our ministry was giving was guided by science, but our president no.
Okay, interesting. So also Chile, I think, has a change on the go at the ministry. Is that what's the relationship? Both countries have a presidential model. What's your take on this, let's say, tension between irrationality and more distance from evidence, from science, Carolina, in Chile, while just observing the change in leadership?
Thank you. I think the situation was not the same as in Brazil. Our ministry resigned because he was like accused of not sharing the information. But it's not that he denied science. I think in that sense, there is a difference. Although I must say that it was the initial strategy was very close in the sense that close in the government. I mean, they didn't invite like in Uruguay the experts, and we did create a COVID council of experts, but they were not really not all their recommendations were taken. So I would be very interested in knowing what was the role of them in Uruguay, if you allow me.
Yeah, sure. That's a good panel interactions. Jose, you want to immediately react to this?
Well, yes, that's a difficult question, a very good question, a difficult answer. The advisory group was gathered by two academies, Academy of Science and Academy of Medicine. And that was united without political color or tendency. Everybody was called because of their expertise. And we produce weekly reports to the Ministry of Public Health and the Presidency. We have not taken any decisions of what to do, that is with the government, but they understood, I think, that the way was follow the best advice, and the four criteria were followed: progressiveness, opening the economic life, protocols to do that, monitoring, and always looking at the scientific. I don't know if that answers you or there is anything else.
Thank you. Thank you, Carolina, satisfied. So now to Carolina from Daniela Espinosa Oyarce. She basically found very interesting the graph comparing the number of cases per SES level and considering the initial cases that were found in ISES sector. What's your take on the early and longer lockdown measures in higher SES areas, and whether they would have had a mitigation impact overall on the number of cases? I think this is a nice question that also linked to a previous one that actually I think it marries quite well, and it extends to all three of you in particular, because it extends to South America, because the response apparently was to the first cases in Italy and so on, 2 months after the peak in Europe, when the first peak, in fact, in South America by and large was around July or June, actually June. So if you can think about the monitoring of the situation and the learning from other countries such as Europe or the US or elsewhere, and whether it had a role in the application of health policy in your country. So it's a combined policy, whether the focus on SES sectors within, particular in Chile, and maybe true also for other, for Uruguay and Brazil, you know, had an impact, or whether it should have been earlier and longer. And on the other hand, whether if you want delayed response compared to what was happening in Europe in fact is a sign of slow policy learning, or whether you think the situation in fact is completely different to actually import policies in a sense. Carolina.
Thank you. I will try to address them, both of them. I think in relation to what we learned from Europe, I think we try to, at least in Chile, we try to do the same in the sense of closing very early and doing all the things that Europe did, but we face different realities from Europe, in the sense that was already mentioned that we have, for example, in Chile, the same as Uruguay, 30% of the labor is not formal, informal sector. That means that if you don't have access, to social security or any savings, you cannot stay at home. So if you do not really tackle that situation at the beginning, the lockdowns are not really efficient, because people is not complying. So in that sense, I think we didn't take into account, that information. We didn't know that it was going to behave different because of that, at least in Chile. And probably we didn't, realize the magnitude of this, the rapid spread. Nobody knew really much about the virus on March, and probably, of course, we didn't do exactly the same. We now know that we should have done a better, an earlier lockdown in some places, or maybe introduce some different criteria for the lockdowns, because we only use 2 or 3 criteria. Maybe we should have also incorporated, for example, overcrowding as a criteria for locking down some, municipalities. And regarding the first question, I answered the second first. I am not sure if the lockdown of the high socioeconomic income municipalities would have been, produce any better result, in the sense that we did neglect the mobility. I mean, many people from low-income neighborhoods travel to high-income neighborhoods to work and things like that. So even if you close the high-level, neighborhoods, people mobilize. They obtained permissions to go into work. So I'm not sure if that measure would have been better. I mean, of course, if you lock down all the country, that is better in terms of containing and mitigation, but you also have to apply, another strategies that I'm sure we didn't do at the beginning, which is testing earlier and massively, also tracking better, or maybe focus it. But I mean, we have a low level of testing at the beginning, and also we have an almost inexistent, tracking system. Especially at the beginning, and when we experienced the surge. So I'm not sure that only, alone would have been really very effective.
Thank you, Denise.
Thank you.
It's not very clear for me what it was working or not at the beginning, because in the beginning it was a mess of information. 1 week, everybody don't use mask. It's not necessary to use mask. After 1 month, it's necessary to use mask. We have a lot of conflicting information, and people don't know what to do. Even the policymakers don't know what to do. And because it was in the summer when it was started after the carnival. People was in the streets celebrating carnival, a lot of crowded people, and the policymakers didn't do anything about this, because this make money, even though that it happens in Italy. But they don't believe at the beginning that it will be happens the same here. Nobody think that it will be like in Europe, in the first moment. it's not very severe. It's not going to happen here. It's summer. It's not a problem. But after the number increased, and then started to have some policies more important. But I think the delay was too much. They could do something before.
Thank you. Jose.
Well, I think that what we can learn from other countries, for example, is the management of borders. We have a border with Argentina that is a water border. People came by boat or by a couple of bridges that are easily controlled. But we have a dry frontier with Brazil, with 4 or 5 cities that are binational and that are limited by one street. And the movement there is really intense and very difficult to control. I hope that the authorities can handle that, putting enforcement and more stringence in the measures. Also, what is going to happen with that, we'll also learn what happened with summer gatherings and overcrowded beaches. That will be very difficult to control. We have not the personnel to put in place protocols in beaches during summer. So that's a question mark over our evolution.
Okay, yeah, so to follow up on this border control issue, so what we observe here, there is a comment about the success of contention related to border controls, strict border controls, in particular in China, Taiwan, Australia, and New Zealand. Yeah, success, you know, with let's say a critical eye, of course, because things went well and then you know, rapidly wrong in all these countries, but to a scale that has been managed in most of them. Of course, the Melbourne case, you know, seems to be related, although it's still being looked at and investigated to somewhat the implementation of those policies, because border controls also have to do with what happens after you pass the frontier and you go in quarantine and how that's managed. Obviously, you know, the argument that it's floating around is pretty much going in this way. So islands are a better place to control their borders. However, we see some, let's say, cases also in LATAM where that strict controls has worked also in countries that are not natural islands. It's clear that in the UK, being also an island, the border controls haven't really worked well enough. Do you think that the natural aspects related in particular to the Chilean and in part also Uruguay, you know, geography could have managed the entry of cases better from the beginning until, you know, the real peak later on? Because it seems that they do have a geography that it's similar or close enough to an island like Spain or France or Italy or Germany or Nordic countries. What is your take, Jose? Your microphone, Jose, you need to unmute.
I think it's a very important thing to consider. If we could trace everybody as we are tracing now, people who is entering, well, that will make things easier. We have a strong connection with Argentina, with families that live partly in one country and in another. So the reunification of that family is very important for the end of the year. So that I think is a factor that we must keep in control.
Okay, Carolina?
I was thinking that, our first quarantine was in a place in the very south of Chile because, a cruise was stopped there and some infected people get off and infected or for a preventive quarantine because of that. But the other, when or where the virus entered, it was because of people flying in planes. So that was the entrance. And now we have an important number of infected people in the very north, where the limits are less clear and it's easy to enter in illegal way. But of course, I think for us, the mountains, for example, with Argentina, is very difficult because we have these high mountains between Argentina and Chile. It's more in the north that you can experience that problem. But I think I won't say that is a problem for Chile. The borders control. I'm not sure about this answer, but what I know is not a problem.
Yeah, good. So to summarize, we should say that the common understanding is clearly that Australia, New Zealand, China, and so on manage very well the control of the borders, the management of the people that enter the borders. Even now, mobility in and out of Australia, for example, is extremely limited, and there is a very strict and severe quarantine. Also, China has the same measures, and that has been a very effective. I'm not sure whether it will be long-term cost effective, but certainly effective in keeping the transmission rates low. So perhaps a space to monitor. I think there is another important question for all the three of you, starting with Denise, in terms of the public-private mix in insurance and provision in your country. Most countries, including Australia, of course, Spain, Italy, you name it, have all of a sudden decided to suspend that mix, basically with, let's say, a surrender or an extra subsidy for the private sector to be, let's say, in fact, made accessible in terms of beds to everyone, right? And of course, that in some countries has meant that private insurance has been sort of altered in terms of claims, because people typically use it for elective care. There is some debate in that area. So what has happened in Brazil, Chile, and Uruguay when it comes to the private and public mix? Denise?
I didn't see any movement to buy beds in the private sector and to put in the public well. In the beginning, they talk about that, but after some months of Luis Henrique Mandetta in the power, this stopped, and only public health care deal with the situation, and people that can pay go to the private one, but people that cannot pay, no way. But the public system was much better than the private one to respond to the COVID. Much more agile, much more better.
Thank you. Very, very interesting. Carolina.
Yeah, on the contrary, in Chile, it was key. The coordination of public and private beds was very important for, referrals, and also to use, to make a good use of capacities, because Santiago, which is the capital, concentrates beds. So the ministry, what did at the beginning was to take kind of control of the coordination of the referrals, and so they send people to other regions sometimes if they don't have enough space or beds in the regional region. So for us, it was very important that collaboration, and that was a faculty that the ministry can use, in these states of emergency. Also, what other things that were for the public and the private systems was for example, the leave, medical leave for patients, but also for close contacts, as well as the coverage of the test and other things that were covered by both system, and it worked. The coordination worked, I think, very well. What we really left out was the continuity of the treatments, because the ministry ordered to stop doing what wasn't necessary, and which of course is understandable, but that now means that we will face accumulated number of treatments and attentions and preventive and I don't know exams and so on. But it worked very well. I think it was very important for Chile.
Thank you. Jose.
Yes, I think this is not an issue in Uruguay. Of course, people can choose for a private system or a public system, but the whole system is integrated and well integrated. For example, in the rural areas or not in the capital, ICU beds are shared between private and public sector. And many times the mutual or private sector doesn't have a high ICU and uses the public ICU. So I don't see a problem in our country with that.
Beautiful. So to conclude, perhaps there is the big news about the vaccine. Obviously, the reality of the vaccine will need to be further, looked at, TGA's approvals and so on. Obviously, there are many questions related to access to the vaccine, and many of the discussions are related and intimately linked also to the framework that exists in every country for accessing drugs, and obviously there is also an intellectual property element that makes the order and the priority in which countries will be served that typically seems until now to follow the standard. So the highest bidders and the payers and the ones that have made a deal, and some countries have done this several weeks ago, seem to have had, and Uruguay is one of them, seem to have secured at least some doses for 10, 20, 30% in some cases of the population. So how is the debate around access to vaccine in the countries? How is it going to be organized? Is there any discussion related to the use of parallel import rules to actually bypass, in the sense, the IP protection and allow for increased production given the public health nature of the issue? And how is the distribution, if that's the case, going to be made more, let's say, capillary in the system so that it reaches to as many people as possible? Denise.
Well, Brazil has a long tradition with a very good programs in vaccination. And now we have at least 2 big research centers that are testing 2 types of vaccines, Oxford in Rio de Janeiro and our university in São Paulo, and also Coronavac from China. The situation in from the vaccine from Oxford is going well. The test is very advanced, almost in the end of the 3rd phase, didn't finish yet, but we signed an agreement with technology transfer, and now Fiocruz is able to produce the vaccine on January. It may be we start the vaccination on March if everything is approved as the rules, the standard rules. And here we are discussing also from in São Paulo, Coronavac is under study yet, but if everything goes well, we are going to produce all in São Paulo also. But even in relation with the vaccine, start a political dispute, and political parts know this vaccine is not good because it's not my part, and the president wants the Oxford. He bought 7 million doses of vaccine from Oxford, and I think that we are going to have more than 2 or 3 vaccines in Brazil very soon.
Okay, Carolina, briefly.
Well, we are participating in the COVAX global initiative, so I think we also get a share of that. And also the government signed agreements with different labs. And I think a couple of days ago, the president told that they have secured vaccines, I'm not sure from which lab, for 8 million population. That means half. So I do know that also we have a committee which is analyzing the different vaccines and the access, and we are now at least organized for that.
Okay, thank you. Very quickly, Jose, to conclude.
Yeah, very quickly. In my experience as a physician, I don't know any other area of medicine as influenced as vaccines by geopolitical power. And we have in Uruguay a long-standing tradition of buying vaccines from the PAHO rotatory fund. And this is what I've done now, signed with COVAX to have WHO approved vaccines when it is ready. I've seen in other countries terrible political discussions and the politicians talking about vaccines and their safety and efficacy as if they know something about that.
Thank you, Jose. Now, I want to thank you all very much. Appreciate it for making this time. I will now hand it to Noel for the conclusive remarks. Goodbye.
Many thanks. That was a great discussion, and many thanks for moderating, Paolo. Let me just share my screen for the last couple of slides. So many thanks to you all, to the panelists in particular, Denise, Carolina, and Jose Pedro. As someone with a non-medical background, it was tremendously informative for me. Thanks too for keeping the time limits. It made for a really fruitful exchange of experiences. Very clearly, no one is saying there's a one-size-fits-all approach, but there are some very clear lessons learned as well. And I think in the course of the discussion, we've heard some really good examples of best practice. If I had to leave today's webinar with a question, it would be how best to share those examples of best practice. Let me thank also Marita Linkson for handling so capably the logistics of today's webinar. And let me just look forward to seeing all of you at the third session next week. It'll be on Thursday, the 19th of November at 9 AM Australian time. That is to say Wednesday evening on the 18th of November, South America time. As you'll know from the program, the third session is going to consider the health impacts of COVID in Central America and the Caribbean. And we'll be looking at case studies in Mexico, Costa Rica, and in Cuba. It would be remiss of me not to mention also special thanks to our supporters, supporting institutions that are flagged on the screen, in particular Plataforma Salud Mental 360, the Australian Studies Centre in Montevideo, the Argentine-Australian Chamber of Commerce, and the Australian Academy of Science. So let me conclude by saying if you have any comments or any inquiries, feel free to be in contact with us via email. Please fill out the evaluation questionnaire, which will be sent to you automatically when the session closes. And many, many thanks sincerely to you all once again for joining us. Until next week, stay safe, cuídense mucho, and hasta la próxima.
Bye, thank you.
Bye. Thank you very much.
Thanks. Bye, Noel. Bye, Marita. Bye, Carolina and Denise.
Thanks.
Bye, everyone.